morning, good afternoon, good evening po sa lahat. San man panig po kayo nung daigdig naroon. Welcome to our 169th episode of Stop COVID Deaths webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and for all those who have just discovered us today, welcome po at sana po marami po kayo matutunan sa ating very interesting topic for today. It's about menopause, which is an inevitable phase of a woman's life, natural biological process marking the end of reproductive years. While a universal experience po, the journey through menopause, very, very deeply personal and unique for every woman. And for many, the symptoms and challenges that accompany this transition can be sort of daunting po. And today, we'll be focusing more about menopausal hormone therapy. In this webinar, we'll be exploring po intricacies of menopause, focusing on MHT. And our goal really is to disseminate the knowledge po and information, dispel any myths that you may have about it, and provide guidance in making informed choices for women's health and well-being. I'm Dr. Raymond Francis Sarmiento, Director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. Always a pleasure to be with all of you during our regular Friday. And as you may have noticed, today, my co-host, she's now back, is our adjunct research faculty at the National Telehealth Center and internationally renowned public health communications expert, Dr. Susie Pineda Mercado. Dr. Susie.
Hi, good afternoon, Raymond. Magandang hapon po sa inyong lahat, wherever you are. And it's great to be back. As we know, I was the Philippine nominee for WHO's regional director in the Western Pacific. And we fought a good fight, Raymond. But,
True.
Congratulations to Tonga, to the Kingdom of Tonga. So now we have the first Pacific Regional Director for the World Health Organization. And the good news is that I'm on the transition team. And I'm also back with you. So, maraming salamat, all of you who have continued to stay with Stop COVID Deaths. We've got a great topic today and really looking forward to hearing from our experts because we bring you credible information from the best of the best. So, we do everything we can to get the speakers who will be able to give you insight and practical advice. And we are, ang pang-ilan na nga to, Raymond?
169th.
Oh my goodness. So this is the 169th episode of Stop COVID Deaths. All right. Now, I'd like to greet all of you who are with us on the live broadcast Zoom webinar, and to all those who are watching via live streaming on TVUP YouTube channel, as well as the UP System Facebook page, TVUP Facebook page, the Stop COVID Deaths Facebook page, and of course, all those of you who are watching on mainstream television through Signal TV, Channel 1 on 101. Our main speaker for today is Dr. Margaret Joyce A. Christie Limson, who is a member of the Board of Trustees of both the Philippine Society for Reproductive Medicine and Philippine Society for Fertility Preservation. Our reactor is Dr. Maria Jesusa B. Banal Silao, who is the current president of the Philippine Society of Climacteric Medicine and was post-president of the Philippine Society for Reproductive Medicine. So as you can see, we have the experts among us today to talk about menopause. Synthesis and closing remarks, of course, will be delivered by our very own Dr. Stella Marie Jose, who is head of the Office of Expanded Education and Training at the UP Philippine General Hospital. And as you know, we started calling this Stop COVID Deaths, but we've now expanded to include other outbreaks, viral infections, and disasters, and many other things, including human developmental stages like menopause. So to proceed with our show, as you know, we are always ready to provide you with the latest news and updates in medicine and public health. And it's for this reason that we bring you the news update.
Okay, thank you so much, Dr. Susie. Our very first news update for this webinar for the week is from the World Health Organization, and a month after world leaders committed to redouble action on universal health coverage at the United Nations General Assembly, 70 countries po, 70 countries have convened to step up primary healthcare investments by 2030. The International Conference on Primary Healthcare Policy and Practice, Implementing for Better Results, it marked the 45th anniversary of the Declaration of Alma-Ata and the 5th anniversary of the Declaration of Astana on primary healthcare. Ito pong conference na to brought together over 600 health policymakers and partners from countries. It took place in Kazakhstan, the birthplace of the historic primary healthcare declarations, co-hosted by the government of Kazakhstan, the World Health Organization, and UNICEF. Doon po na pag-usapan, more than half of the world's population is still not covered by essential health services, and 2 billion people facing severe financial hardship due to healthcare costs. Ang pinag-usapan po nila doon is to have more and greater investments in primary healthcare and making the most of digital innovations. That's number one. Number two, ensuring protection from catastrophic out-of-pocket health costs. And number three, investing in the health and care workforce to address the projected na 10 million, 10 million na health worker shortage by the year 2030, and that is just 7 years away. What about you, Dr. Susie?
Thank you so much, Raymond. From the Department of Health, in partnership with local government unit of Sorsogon City and the Sorsogon State University, they have brought the Byaheng Kalusugan to Sorsogon City in celebration of National Mental Health Month. During the event, engaging activities for students in the university. These were held to raise awareness on mental health concerns, address common misconceptions, and provide active care for mental health and well-being. Centered around the concept of Feeling Eskwela, the event aimed to provide an avenue for students to learn about the importance of acknowledging and processing their feelings. The activities underscored 3 key goals. 1, equipping individuals with knowledge and tools, enabling the practice of self-care. 2, fostering improved health-seeking behavior. And 3, cultivating a positive attitude toward mental health while supporting others on their mental health journeys. And that's our news for today. We'll be back next week with more news on the News Update. Okay, and we're back, Raymond. Let's see. Parang nawawala na ako, no? Okay, back to our topic. All right.
Yeah.
So I'm looking forward to hearing more about how hormonal therapy can help manage menopausal symptoms such as hot flashes, mood swings, and sleep disturbances, as well as its role in preventing osteoporosis and heart disease. But before that, Raymond, you might want to introduce our person on the street interview.
Thank you, Dr. Susie. To set our discussion into context, and this is for the benefit of those joining us for the very first time, we have what we call person on the street, or our POTS video, wherein we take the pulse of the common folks on the street to determine po what they know about the topic on hand before we talk about our webinar topic for today in more detail. We asked them several questions, and these are those questions. Alam nyo ba kung ano ang menopause? Ano-ano ang nararamdaman ng isang taong nagme-menopause? Okay? Alam nyo ba ang tungkol sa menopausal hormone therapy? Alam nyo ba ang mga benefits ng menopausal hormone therapy? Yeah, please watch this.
Pagkakaalam ko, pag meron kang menopause, mainitin ang ulo.
Ang menopause ay is a state in which a woman has entered a high FSH and LH levels. A woman's estrogen is no longer, or its levels are no longer high enough.
Yes, yung hindi ka na nag-menstruate, yung monthly period mo, wala na.
Ibig sabihin yan ay ang babaeng hindi na nagre-regla sa loob ng 12 buwan o 1 taon.
Hindi ko masyadong familiar dun or hindi ko alam kasi hindi pa ako nakaharanas.
Could be multiple. Symptoms could be multiple. But one thing that I know for sure is that a woman or an individual experiencing menopause would enter in a state of hot flashes, and even the more bizarre symptoms. It could also lead to osteoporosis.
Pinakamadalas na nararamdaman ay ang tinatawag na hot flashes, no? Ito po yung hallmark kasi yun yung init na init ang kanilang mga katawan at maaring tumagal ito ng ilang segundo or minuto, maaring minsan lang sa maghapon. Bukod doon sa hot flashes, pwede rin yung tinatawag na night sweats. Sa gabi naman, biglang papawisan na parang init na init siya at pawis na pawis at ganun din, maaari ding tumagal ito ng ilang segundo o minsan ay minuto.
Dati I don't believe on what my peers were saying, but when I experienced it, I clearly believe na very na siya, incomparable sa hindi ka pa menopause. Kasi meron na dyan yung mga hot flashes, tapos yung bones mo na parang may uric acid. You cannot even explain kahit na naka-aircon ka, pinagpapawisan ka, tapos somehow may moody ka eh. Nagiging moody, may mood.
Ay, hindi ko po alam kung ano yung therapy para sa menopause.
I've also heard of the menopausal hormone therapy. It's a therapy that's used to replace the hormone estrogen in women experiencing menopause.
Yun po ay paggamit ng mga gamot para maibsan ang mga nararamdaman na ito habang nagme-menopause, no? Ang menopausal hormonal therapy ay magpapaalis ng mga nararamdaman natin na vasomotor symptoms, katulad nga po ng hot flashes at saka yung night sweats. Ina-address din po niya o papagaling din niya yung mga simptomas ng dryness, no? At yung paulit-ulit na pagkakaroon ng urinary tract infection at discomfort.
Ay naku, sorry, wala akong idea dyan na meron palang therapy ang hormones. For sure, kung meron yan, maganda yan. Na sana maging aware tayo.
So the benefits of the menopausal hormone therapy, such as bone growth, relieving of mood, or to also have benefits in the cardiovascular system of a woman.
Bukod po doon ay meron din siyang magandang effect para hindi magkaroon ng pagnipis ng buto ang mga babae or osteoporosis. May mga pag-aaral din na nakakabuti ito sa ating pag-control ng ibang mga sakit tulad ng high blood or kahit sa diabetes.
Okay,
Nakamute.
thank you so much,
Okay.
UP, for that. Ako rin, Raymond, hindi ko alam yung menopause. Tapos na po ako dyan. Tapos na po. And I'm curious because I was told not to use hormone replacement therapy because I had cancer, a very strong history of cancer in the family. So breast cancer, endometrial cancer, mga ganyan. So gusto kong malaman kung ano yung mga bagong mga pangyayari. So nung nagka-menopause ako 2 years ago, ay joke, hindi, matagal na. Wala naman akong I think some people have really severe symptoms, but I was okay. Hindi naman umiiyak yung mga anak ko. Hindi naman nagagalit yung asawa ko. Yun lang, naka-electric fan ako palagi paggabi. So let's continue to talk about this, reflect on it, and think about it. And I think this also helps us gain more understanding for people who are going through menopause and provide options so that we can prevent some of the side effects. Okay, Raymond, housekeeping ka muna.
Thank you, Dr. Susie. For those who are asking, we've already sent out all of the certificates of attendance from 1 to last week po, 168 certificates of attendance. Again, certificates of attendance will be given only to those who have watched at least 50% of the webinar duration. If you feel you should have received one but did not, please let us know at stopcoviddeaths@up.edu.ph. For our webinar today, we'll be having a standard panel discussion format, and after our speakers have presented, that will be followed by a Q&A session. But before we delve into the webinar proper, we have a cute intro video for our fun quiz segment for today.
Hello? Hello? Hello?
Kumusta na kayo lahat?
Hi, I'm Doc Susie, the mini Doc Susie.
And I'm Doc Radar, the mini Doc Raymond. Are you ready to have fun? Simply open your browser to www.slido.com and enter your code to participate. We will discuss your answers during the panel discussion later on in the program.
We will have it flashing on your screen in a bit, and we look forward to your answers. Masaya at madali lang ito. Join na!
Oh, parang Little Mermaid pa rin, Raymond, ano? Okay.
That's true.
Okay,
May
go
we
ahead,
have on the
Raymond.
screen po yung ating Slido and also yung Zoom dito po sa ating Zoom webinar. Okay, so for those who are joining us outside of the Zoom, you may be able to still participate in our fun quiz by opening up your browsers. You enter in the address bar po, no, you type in slido.com, and when you are prompted, you enter the code 6510096. That's 6510096 for you to be able to participate in our fun quiz segment. For today, we have two questions. The first question po, no, I said, and just like in our previous webinars, we'll ask our experts for the correct answer to these questions. Our first question reads, when should one start taking menopausal hormone therapy? So kailan daw po ba ito inuumpisahan na i-take para po sa ating may mga eligible po na mag-take po? Letter A, within 10 years from the onset of menopause or before 60 years old. Is it B, after 10 years from the onset of menopause? Is it C, after 60 years old? Or is it D, none of the above? We'd like to take this opportunity to greet those who are joining us all the way from the Overseas Filipino Workers Hospital in San Fernando City in Pampanga, the Santa Rosa Community Hospital in the city of Santa Rosa, Laguna, Western Visayas Medical Center, Iloilo City, maraming salamat po. Colegio San Agustin in Bacolod City, Negros Occidental, thank you. Camp Navarro General Hospital, Zamboanga City in Zamboanga del Sur, Mindanao State University in Marawi City in Lanao del Sur. There are those joining us all the way from Bataan, from Los Baños, Laguna, from the University of Rizal System Health Services Unit, from Deca Homes Loma de Gato in Marilao, Bulacan, from RPHS Annex 1 in Antipolo, that's the province of Rizal, province of Cavite as well. Rizal again, those joining us from La Consolacion University Philippines, Malolos City in Bulacan, maraming salamat po. From Northern Samar, our avid viewers din po and masugid na taga-pagsubaybay. Our second question reads, what are the indicators for MHT, so menopausal hormone therapy? Is it A, what are indications pala, sorry. Is it A, moderate to severe vasomotor symptoms? Is it B, prevention of osteoporosis in postmenopausal women? Is it C, moderate to severe vulvovaginal symptoms? Or D, lahat po na nabanggit, all of the above? We'd like to greet those because you already know that we are being watched din po, no? Including in the playback internationally, those are avid viewers from the Chonin Hospital in Taipei City in Taiwan, the Lunichi Ali University of Blida 2 in Blida, Algeria, Island Hospital in Penang, Malaysia, Los Angeles in California in the United States, Manteca in California in the United States, University of Hail in Hail, Saudi Arabia, and the Canadian Medical Center in Dammam, Saudi Arabia. So, we encourage everyone to enter in your answers to these two fun quiz questions as we move on to our webinar proper, and Dr. Susie will introduce our main speaker for today.
Thank you very much, Raymond. And let's go to our main speaker. I think everyone's waiting for our presentation, and we would like to welcome a member of the Board of Trustees of the Philippine Society for Reproductive Medicine and the Philippine Society for Fertility Preservation. Please welcome Dr. Margaret Joyce A. Christie Limson. Dr. Majoy, welcome.
Hi, thanks for the warm welcome and thanks for having me here. Good afternoon to everyone. Good morning and good evening to those who are not in the same time zone as us.
Sige, go ahead, Doctor.
Okay, so
The floor is yours.
okay, ma'am. So let me just put in my slide. So I'm glad that we were actually asked to discuss, to be part of this show, to discuss menopause. So as a matter of fact, ito pong October, it is the month that we celebrate World Menopause Day. And for the Philippine Society of Climacteric Medicine, the theme was Byaheng Menopause, Malusog, Masaya, at Marikit. Now, for today's discussion, I would like to discuss the role of menopausal hormone therapy and concentrating more on how it came out of favor and how we would like to inform the general public, the doctors, and the people that it is actually something that we should put back in the armamentarium in the treatment of the symptoms that women experience when they have menopause. Okay, so what does menopause really mean? So meno means menses, and pause or pauses means cessation. So it is the cessation of menses and connotes the final menstrual period of a woman, okay? And it reflects the loss of ovarian follicular function. So it is actually a diagnosis that we reach as retrospectively. It means that 12 months from the last menstrual period, so after only 12 months is when you can say that a woman is actually menopausal. So women, according to data, the usual age of menopause for the Filipino woman is actually the age of 48, but in Caucasians, it will be around the age of 51. Now, some women will go through menopause without symptoms. Wala pong nararamdaman, not significant like Doc Susie, but most will have at least one or more of these symptoms. So very prominent yung hot flashes, okay, or hot flush, and it will feel like a wave of heat that comes from inside, and then allegedly, it will move up to your chest and face and move throughout the rest of the body. Now, for some women, this can be very, very significant, okay, because it actually disturbs them from their work. They have to stop what it is that they are doing. So hot flushes will usually start, okay, during the perimenopausal years. So not just when the woman actually stops having her menses. So it can actually start during the perimenopause or the time leading to menopause. Now, some women will also complain of night sweats. So this is sometimes when the hot flush will happen during sleep. So init na init when they're sleeping, so night sweats. And it can actually make it very hard for a woman to get a good night's sleep. So we're not very surprised, when a woman who is sleep deprived during the day might actually become more irritable. Now, again, sleep problems, okay, during the transition to menopause, some women have trouble falling or staying asleep. So this aside from the night sweats, okay, so this can really be a problem even if night sweats are not an issue, okay? Some women down the line will actually complain of vaginal dryness or what we call genitourinary syndrome of menopause. Now, menopause will cause the collagen to actually decrease, and it will cause the vagina and tissues near the vagina to become very dry and very thin. So this will usually start a couple of years, maybe about 10 to 15 years from the onset of menopause, and it can make intercourse very uncomfortable for some women. Now, some women will also complain of depression, okay? So there will be this sense of sadness, and they will lose interest in doing things and sleep too much or sleep too little, okay? That's especially true for women who have a history of depression, okay? And some women will actually complain of trouble in concentrating or remembering things, okay? So some experts believe that estrogen, or the hormone that is lost during menopause, is important for good brain function. So this is a slide showing the spectrum of effects of estrogen deficiency starting from perimenopause or during the earlier part of estrogen deprivation up to advanced age. So early on, so pwedeng hindi pa po menopause yung patient, okay? So the perimenopause or early menopause, women will usually complain of the vasomotor symptoms. So that will manifest as hot flushes or the sweating. And then there's also insomnia. Of course, there will be the menstrual irregularity. Again, it will be 1 year of no menses before we say that a woman is actually menopausal. And some patients will actually, or women will complain of psychological symptoms such as irritability. Now, a couple of years down the line will be the intermediate symptoms, and they are usually manifestations of collagen-related issues such as genitourinary syndrome of menopause. So there's vaginal atrophy, okay, painful intercourse or dyspareunia, and skin atrophy, and some will complain of urge stress incontinence. And late issues of menopause will include osteoporosis, atherosclerosis or coronary heart disease and cardiovascular disease, and Alzheimer's disease. Now, there was a study published in 2008 that showed that the most common symptoms of Filipino menopausal women is not actually the hot flush or the sweating. It's actually the physical and mental exhaustion. Okay, maybe the hot flush. No, this is only the 7th complaint. Only 68% of the women surveyed, as compared to 81% who complained of tiredness and joint and muscular discomfort. Now I go to menopausal hormone therapy. So menopausal hormone therapy remains the most effective treatment and should be considered in women younger than 60 years within 10 years of their final menstrual period and without contraindications. So again, it is the most effective treatment, particularly for vasomotor symptoms, and should be considered in those less than 60 years within 10 years of their final menstrual periods and without contraindications. So this second line, I think, answered one of the questions that was posted earlier. Okay, so this is also a very important concept to remember because this is a concept of window of opportunity. And we will always be going back to that when we discuss menopausal hormone therapy. So what are the indications for the use of menopausal hormone therapy? It is the treatment for postmenopausal women disturbed by symptoms of hormone deprivation. So hot flushes or atrophy of the reproductive tract, again, this is GSM. But it's just not like you having some hot flush, you'll take MHT. They said it has to be severe symptoms, okay? The second will be, it can be used as a prophylactic agent against osteoporosis. And the third is for premature hypoestrogenism, also for women who have hypogonadism or early menopause or primary ovarian insufficiency, gonadal dysgenesis, and premature surgical menopause. Now, there's the story of HRT and how it became in favor and then nawala po sa uso. So, over the years, it has shown a trend with 2 peaks of utilization. So, the first one when it was actually first introduced in the market in the 1960s. But then they realized that giving back estrogen, it's just plain estrogen, they realized that the incidence of endometrial cancer increased. That's when they discovered, oh, we should be putting progesterone, giving progesterone to these women to protect the uterus. And then there was an increase until the early 2000s, until the data from the WHI or Women's Health Initiative came out. And after those years, after that peak, so many people stopped menopause, MHT. So many doctors stopped giving it because they were afraid. And this is what I will go to discuss the subsequent slides. Is MHT safe? Okay, is this something that is okay to take? And we would like to establish that it is actually something safe and it should be given to women who actually need it. So in 1960, so they had this thrust, feminine forever. And during this time, they discovered the effect of unopposed estrogen and the endometrium, as I mentioned earlier. So they tapered the dose of the estrogen and added progesterone for endometrial protection. In 1988, the FDA approved MHT for hot flushes, and there were claims that it had a positive effect on cardiovascular health. So the FDA said that maybe you should make studies to confirm this benefit. So in 1993, the Women's Health Initiative Study, or WHI, was started. In 1996, another study, but this one is in UK. They started the Million Women Study. Okay, this one was concentrating on breast cancer outcomes. The Women's Health Initiative concentrated on the cardiovascular outcomes of the use of MHT. However, 2002, so this was the WHI study stopped the estrogen and progestogen arm because they found a small increased risk of breast cancer, heart disease, stroke, and blood clots. And the year after, the Million Women Study published their results, and they said that women currently using combined hormone replacement therapy, so when we say combined, it's estrogen plus progestogen, were more likely to develop breast cancer. So scary, right? So the Women Health Initiative, I'd like to discuss this in detail because this was the study that affected the course of the use of MHT. Okay, of course, it also had a significant effect on the women who were using it or the women who were supposed to take it, okay? So it studied over 16,600 postmenopausal American women aged 50 to 79. So they started it from 1993, but they terminated the estrogen arm 2002, and they terminated the next arm, estrogen progesterone arm 2004. So the mean age of the participants was actually 63.3, so a bit on the older side, right? And they looked at the effects that HRT had or MHT had on the heart disease and other aspects of the woman's health. Okay, so this was how they followed up the women. So they had a phone call with clinical visits, so on and so forth. So in 2002, they terminated the estrogen plus progesterone trial because they found or they published that there was an increase in coronary events, stroke, breast cancer, and vein blood clots. So over 1 year, 10,000 women on combined estrogen progesterone treatment compared with placebo had 7 more CHD events, 8 more strokes, 8 more pulmonary embolism events, 8 more breast cancers, but they also showed that there were fewer colorectal cancers and fewer hip fractures. So protective for colorectal cancer and protective for osteoporosis, but all the others, cardiac, and vascular, not good. So they said because overall risks were thought to exceed benefits, they decided to stop the trial, and the information was disseminated worldwide through the media. 2004, the estrogen arm trial was terminated because they found that just giving the estrogen increased the risk of stroke and venous thrombosis. However, they did not find an increase in coronary events, but they also did not find any protective effect in terms of colon cancer. And there was still a decrease in breast cancer and osteoporotic fractures. So what did the critics say? Okay, what was the response to the data that came out? They were saying that MHT or hormonal therapy is not safe. Okay, so they said that the WHI studied only effects of continuous hormone therapy, but what about cyclic hormone therapy? So sometimes you give combined estrogen and progesterone in a continuous manner, or we just give estrogen continuously and give progesterone for about half of the month. So that is what we call cyclic hormone therapy. So the differences in cardiovascular events and strokes are statistically non-significant after adjustments to correct for multiple analysis over time. This one is significant. They also found out and that they also said that the mean age of the women in the WHI study population is actually 63.3. So medyo matanda na po, no? And we were questioning, can the results actually be generalized to the younger, recently menopausal women in their 50s? Okay. So they also said that what is statistically significant may not actually be clinically significant. For example, how does one view the 0.08% increased risk in breast cancer? How does that correlate clinically. So the flaws of the WHI study, the WHI looked at only one dose, so it's still fairly high, and type of combined HRT or estrogen-only HRT, and the dose that was used, while appropriate for a younger woman who is healthier, was considered to be too high for older women. And the majority of the women in the study were not only older, 63 years old, right? Their average BMI was high. They're overweight, 28.5. And this in itself is a recognized risk factor for heart disease and certain cancers, including breast cancer. Now we go to the Million Women study. So this is a study that was conducted from 1996 to 2001. So 1 million women who were surveyed in the UK over 50 years old as part of their breast screening program. And they looked at the risk of breast cancer and other health issues related to MHT or HRT users compared with non-users. And they found that estrogen-only HRT caused a small increased risk in breast cancer, uterine and ovarian cancer, and combined hormone replacement therapy increases the risk of breast cancer more than just estrogen alone. So now we're looking at, is the progesterone a significant medication or that causes an association with increased risk of breast cancer? Okay, so the longer the HRT is used, of course, the higher the risk of breast cancer, and the risk of breast cancer actually disappears as soon as the use of these hormones stop. Okay. Now, across the world, the message from the media, okay, the truth about hormones beyond hormone therapy, you stop it. So as a personal note, when my mother was surgically menopause in 2003, I told her, stop taking the hormone replacement therapy. She was actually miserable after that. She suffered from significant vasomotor symptoms, but I told her it was unsafe. So I told her, stop taking the MHT. So we were all affected by that. Her quality of life was not very good, but she's still okay now. But see the effects of this stopping the MHT, because it was really sensationalized during this time. This was 2002 and 2003. Okay. But in the following years, the data was actually reanalyzed and new studies actually showed the benefit of HRT, and there was there were more and more studies that were made. So 2004 to 2007, the WHI data was further analyzed, and they found out and they admitted that the risks for certain safety aspects were actually overestimated. So tinakot lang nila tayo. And there are actually additional benefits of using HRT or MHT for those initiating HRT when the results were split down by age. Okay, so this is a very important concept. Those starting MHT under the age of 60 and or for those less than 10 years past the menopause. So again, this is the window of opportunity. So they actually found that there were trends to a lower risk from heart disease, a lower risk of death from any cause, and no clear increased risk from stroke. Okay, so the general increased risk for those starting or initiating HRT is actually after the age of 60. So sabi nila, safe siya, and actually with benefit for those who started within the window of opportunity. And in 2012, there was actually a study that was published by the Danish cohort, okay, of the use of combined HRT for 10 years in healthy women started shortly after menopause, actually validated the WHI results. There was reduced heart disease and mortality in these women. 2012 again, further report from the Million Women study, the UK group, showed that there was no increased risk of thrombosis or blood clot formation with the use of a specific type of HRT, so transdermal skin patch or gel estrogen hormone replacement therapy. So now we know that this is one of the safer ways to actually administer hormone replacement therapy. So again, when split down to age, if you look at the blue, 50 to 59, generally safe. CHD, stroke, breast cancer, and total death. But as a woman ages, the risks are very obvious. 60 to 69, we see an increased risk of stroke and venous thromboembolism and total death, and obviously for those who are even much older than that. Okay. So in 2019, the collaborative group on hormone therapy for breast cancer, so prospective study of 108,647 postmenopausal women who had used HRT in their lifetime, they declared that the risk of breast cancer is actually duration dependent, okay? But it is increased with both estrogen only and combined HRT, but that's increased risk of breast cancer is greater in those who are using combined estrogen and progesterone therapy. Continuous combined preparations demonstrated greater risk than the one that is cyclic, and the study did not report on breast cancer-related mortality. Okay, this study actually also showed that obese women using estrogen-only HRT added little additional breast cancer risk to their already baseline elevated risk, but the lean or obese women had the same additional risk when using progesterone or combined HRT. Now, the Women's Health Initiative 2020, so this is really 18 years down the line, they found that they declared or they published that the WHI long-term report on breast cancer incidence and mortality on 27,000 women who were followed up until 2017. Again, they reported that the increase, it reported that women using estrogen-only HRT actually had a reduced risk of breast cancer incidence and mortality. But again, it's the combined HRT that has shown that actually had an increased risk of breast cancer. Okay, now this did not translate to increased risk of mortality because these patients, those who are taking hormone replacement therapy or who took it, were actually being followed up by their doctors. So if there's a breast tumor that is detected, then they are treated earlier. So they also reported on an increased risk of invasive breast cancer and breast cancer mortality in obese women. So if you look at it, they said that maybe even being obese is a higher risk factor for breast cancer than taking combined HRT. So regarding cardiovascular disease, they reported again, okay, that women starting or initiating MHT or HRT within 10 years on the onset of menopause or under 60 years, that window of opportunity, actually have a lower risk of cardiovascular disease, cardiovascular-related death, and all-cause mortality. So I think that settles it already. Now, what are the feelings towards receiving hormone therapy among those with vasomotor symptoms from France, Germany, Italy, Spain, and UK? This was already 2020 data. If you look, this one, eligible but adverse to using hormone replacement therapy, it's 50 to 68%. The damage has been done. 18 years from the time that WHI initially published their study, and after even many years of a lot of data showing that it's actually untrue, people are still afraid to take hormone replacement therapy. Okay, so this is what we're trying to do now. We're trying to say, if you need it, you can take it. It can be safe and it can be helpful. Okay, so the latest data regarding heart disease risk and benefit, the window for opportunity, if you give it during that time, you start it during that time, there is no increased risk in cardiovascular disease. HRT does not affect the risk of dying from cardiovascular disease, and HRT with estrogen alone. Estrogen alone HRT is associated with no or reduced risk of coronary heart disease, and cardiovascular risk factors in patients are actually not a direct or a contraindication to HRT use as long as the medical problems are generally appropriately managed. Now, starting on HRT at age greater than 60 or after that window of opportunity, HRT appears to increase the risk of cardiovascular events, cardiovascular mortality, or all-cause mortality. So in terms of cardiovascular effects, it is considered safe if it is started with during the window of opportunity. For breast cancer risk, there is truly an increased risk, and it is usually associated with the use of progesterone. Some progesterone preparations are considered safer than others, okay? So the risk is actually not very high. So the increased risk with combined HRT was much less than initially reported. So you can quote it as 4 extra cases per 1,000 women after 5 years of use, okay? It seems to be duration dependent and may vary with the type of progestogen used, as I mentioned earlier. And specifically, it would be micronized progesterone and dydrogesterone that are considered the safer progestogens to be used if you're going to use combined HRT for patients with intact uterus. Now, for ovarian cancer risk, a 2015 meta-analysis of 52 studies showed an increased risk of ovarian cancer when with estrogen only and combined HRT. However, with 5 years of use, there could only be really just 1 additional ovarian cancer per 1,000 users and 1 additional death per 1,700 users among women of all ages. So after 5 years of HRT, there's actually only a 0.1% increase in ovarian cancer and less than 0.6% additional deaths. For stroke, oral, the intake of oral MHT, but not the transdermal, which we consider safer, is actually associated with a small increased risk of stroke. However, the baseline risk of stroke in women aged less than 60 is actually very low, so this increase is considered non-significant. The risk is actually increased in women who smoke and are overweight. So you'll have to take those two into consideration when you're stratifying the risk of these patients who you're considering to give hormone replacement therapy to. Okay, so the question now is hormone replacement therapy or menopausal hormone therapy for all menopausal women? First, it has to be clear. Is it indicated for that woman? Okay, again, I'll show to you again the indications for hormone therapy in menopause. So the indication has to be clear, okay? First is the treatment for postmenopausal women disturbed by symptoms of hormone deprivation, particularly severe hot flushes or atrophy of the reproductive tract. Can also be used as a prophylactic agent against osteoporosis and for those who are manifesting with premature hypoestrogenism. Now, what are the contraindications? Okay, the use of MHT. So in general, menopausal hormone therapy should be avoided in women with any of the following conditions. Those who have abnormal uterine bleeding. Okay, so we do not know if this is already endometrial cancer. So we do not give our hormones to this patient. Now, known history of estrogen and progesterone receptive cancer, such as breast cancer, advanced stage endometrial cancer, so FIGO stage 2 and above. So early stage endometrial cancer, it is considered safe to give it to women who had endometrial cancer stage 1. But of course, kailangan pa rin pumbantayan yung mga pasyente niyan. So known history of uterine sarcoma, history of low-grade serous and clear cell epithelial and sex cord stromal ovarian cancer, and known history of advanced stage malignant melanoma. Of course, if a patient has a deep vein thrombosis, pulmonary embolism, or history of these conditions, you cannot give your MHT anymore. Or active or history of myocardial infarction, stroke, or unstable coronary disease, and inadequately controlled arterial hypertension, you cannot give it to these patients because there's already established or the presence of cardiovascular disease for these patients, so it will be considered unsafe. Okay, so for those who have known anaphylactic reaction in response to any ingredients in that medication, active liver disease or the presence of liver failure, or known protein C, protein S, antithrombin deficiency, or other thrombophilic disorders, and porphyria cutaneous tarda. Now, the first couple of ones that we mentioned are actually hypercoagulable states, so we do not give the estrogen to these patients as well. So back to the question, is MHT for all menopausal women? So MHT or HRT, whether combined or estrogen alone should not be recommended without clear indication for its use. It should also be individualized and tailored according to symptoms and the patient's healthcare needs. And the recommendation is to use the lowest effective dose and the shortest duration. So, as a matter of fact, there are no guidelines on when to stop the use of MHT. It doesn't mean that you hit 60, 62, 65, that you have to stop it. It will always be a constant dialogue between the physician and the patient on when they think it is best to discontinue the medication. So you should initiate during the window of opportunity within 10 years of menopause and not older than 6 years old. And the decision to continue MHT is individualized. So that is my last slide, and thank you for your attention.
Thank you so much, Dr. Majoy. Very, very well delivered. Comments from Dr. Susie.
Thank you very much, Majoy. I learned so much and I realized that I fell in that time when there was a scare around hormonal therapy. So, magandang malaman yung history tsaka yung how science progresses. So, I hope this will really help a lot of our listeners. Sige, Raymond, over to you.
Thank you so much, Mama Joy. We hope you're ready for a lot of questions later on during the Q&A. And thank you so much also to Dr. Susie. So we'll go ahead to our next speaker, who is our reactor for this webinar. She is the current president of the Philippine Society of Climacteric Medicine, past president of the Philippine Society for Reproductive Medicine, and right now she's vice chair for research and associate professor 7 at the Department of Obstetrics and Gynecology at the Philippine General Hospital. Please welcome to your screens Dr. Maria Jesusa Banalsilao. Dr. Agates. You're on mute, ma'am.
Good afternoon. Thank you for the invitation. Allow me to share my slides for, kasi this is Zoom, so it's easier to react with the slides. Okay, so thank you, Majoy. That was a very prolific presentation on the use of hormone therapy. So we borrowed this theme. So this is like what Majoy said. World Menopause Day is actually celebrated October 18 internationally, but in the Philippines, the Philippine Society of Climacteric Medicine pegs the whole month of October as the month of menopause. So as we speak, there are regional hospitals celebrating Menopause Day. And the international theme is actually towards cardiovascular health. That's why it's an appropriate theme to redefine menopausal hormone therapy. So Majoy also reiterated the onset of menopause in Filipino women. So we're a bit younger, but the society is again hoping to do a nationwide research to reassess if we're still at the 48 years median age of onset. I would like to emphasize these two special populations. So early menopause is when the woman stops menstruating between 40 to 45. This is still physiologic, but it's more concerning in a way because these women, we know that if you lose your estrogen earlier in life, you are more predisposed to the risk for earlier cardiovascular disease, osteoporosis, even cognitive decline. And premature ovarian insufficiency is not physiologic, pathologic po ito. So when you don't menstruate younger than 40, then you should be evaluated right away. And these two special populations will benefit mostly from the use of menopausal hormone therapy. So what is the concern now in the menopause in the new era? So we've been seeing women living longer. And as a result, in the new era, we also have more career-oriented women. So as much as a third of our lives are spent in the postmenopausal state. And with post-movement pregnancy, we take care of our careers. A lot also of our women age with toddlers at in their midlife. Okay, so although menopause is a natural transition, the changes that go with it may be associated with short and long-term health consequences. Okay. So this is just a graph showing us that in the early 70s, the median age of expectancy, median life expectancy in women is only in the 60s, but now we get to live past 70s. I think Korea is pegged as the oldest person, no, past 105, surpassing Japan. Okay. So like what Majoy mentioned, although hot flushes, so the description was already very intricate, is the hallmark. It's not really as common universally. So we know we're a tropical country. So this is a pan-Asian study involving 11 Asian countries. So we are here, Filipinos. So in this table, we see that hot flush is only down the line, but the number one complaint of Asians seem to be body or joint aches and pain. So please do not disregard when your patients complain of these and you do not address them. So this is part of the spectrum of menopause. And with this pan-Asian study, it was shown that the patients, even if they were given the lowest dose of the combined estrogen-producing therapy, they were alleviated of these concerns. Okay? So why are we even discussing, why are we here in this webinar now? Because 70 to 80% of women are affected by menopausal symptoms, and a fourth of us will describe the symptoms as severe, meaning it affects or debilitates their quality of life. And although we see an average duration of symptoms to be as short as a year or long as 7 years, in some cases, they may still persist past the age of 60. Okay, so can you imagine living in this life with the mood swings, headaches, fatigue, and depression? I empathize because I felt all of these when I hit the menopause. So not only should we be concerned about telling them that, oh, this will address your immediate complaints, but equally important are the long-term health consequences, which they do not see for now, like osteoporosis. That's why we call it a silent disease. Perfect example is my mom used to be taller than I am, and now she's shorter because of the vertebral fracture, which you do not really see or feel, but sometimes it manifests as a shortened height, right? And the incidence of depression has been shown to be increased in menopause, independent of other confounding factors. Ito yung wala pong treatment as of now, right? Cognitive decline or Alzheimer's disease, because estrogen is cardioprotective, neuroprotective. So when we lose our estrogen, we are more at risk of having cardiovascular disease, cognitive decline. Cancer is not because of menopause, but it is more age-related. That's why we monitor these women. And like what Majoy said, other factors like obesity, social habits, if the patient is a smoker or a heavy alcohol drinker. So this, again, increase the risk of their cancer incidence. And menopause is clearly associated with an increase in all-cause mortality. Okay, so just a special mention, kasi we keep getting scared. Unfortunately, sometimes even the practitioners are scared of prescribing because of the big C of breast cancer. But we underestimate the incidence or prevalence of osteoporosis in Filipino women. So it's not low. It's pegged to be almost 20%, and a higher prevalence of fractures in females than in males. So this is local data. So now I would like to share with you this beautiful statement that I got from a journal, and it states that our modern world now has produced a new type of postmenopausal woman. We are active in work and at home. We are independent in our choices and actions. Postmenopausal women are valuable members of modern society. They have knowledge and skills accumulated through life experience. So we should see these qualities as an opportunity and resource. So now we have a shift. We should also aim towards prevention. So like I said, some diseases such as coronary artery disease and osteoporosis are menopause-related and accelerated with loss of estrogen. And some, such as cancer, are age-related. That's why the onset of menopause is sort of a sign for us to intervene and screen to enhance and improve the quality of life and promote longevity. And in this sense, the hormone therapy can be an important sort of preventive tool in both improving the quality of life and potentially reducing mortality. So we are tasked, healthcare providers, to discuss, assess, and prescribe interventions to our women. And special attention, like I mentioned, to those who achieve their menopause earlier in life, the 40 to 45 age group, and those who unfortunately have POI, less than 40 years old. These patients are at an increased risk for accelerated cardiovascular and central nervous system disorders, thus warrants MHT. So how do I advise our patients? Of course, we start with telling them to live a healthy life, have that exercise, have a healthy diet, cut down on smoking, limit our alcohol intake. We start doing our cardiometabolic surveillance, meaning we check the lipid cholesterol profile, we check their sugar levels, weight, the blood pressure, the waist circumference. We also start our cancer screening. So we know we start mammography at age 40, colonoscopy at age 45, or at least a fecalysis. We do our cervical cancer screening and a transvaginal ultrasound for ovarian cancer. And then we may consider the use of menopausal hormone therapy for prevention. So a lot of meta-analysis studies have shown a consistent 30% decrease in all-cause mortality with menopausal hormone therapy users. So it affords protection from osteoporosis, reduces menopausal symptoms, and improves overall quality of life. So this is not a myth. So these are just a few of the evidences. So if you see here, the WHI trial, which Madroy earlier mentioned, the initial trial included an older age population, but when they did surveillance analysis on the 50 to 59-year age group and monitoring them past 18 years, so there's a protection of 30%, okay? And also with Cochrane meta-analysis. So Madroy already mentioned, but this is just quoting the most recent. Madroy, I would like to update the group that the society that was at 2017 clinical practice guidelines, but we just finished deliberating and we will be out with the 2024 clinical guide to menopause, to the menopausal women in the Philippines. So we updated the 2017. So this is in harmony with the 2022 NAMS recommendation. So these are the 4 indications for giving our menopausal hormone therapy. So for women who have moderate to severe vasomotor symptoms that affect the quality of life, to prevent osteoporosis in postmenopausal women, to treat hypoestrogenism caused by hypogonadism, or those who had, like what I said, an earlier removal of ovaries and premature ovarian patients, and to treat patients with moderate to severe vulvovaginal symptoms, because the first line recommendation for these are really just the vaginal estrogen. Okay. So just to augment Madroy's lecture, so we have several preparations. So we have the local, so it's either we put in the vagina, so like rings and pessaries are not available locally, but we have creams. Systemic, it's either the tablet or transdermal gel. We don't have the patch or the combined implant, but we have the progestin implant. So we have the estrogen gel, which is like what Madroy mentioned, because of the bypassing of the first pass effect of the liver, it's safer for those with risk factors for coronary heart disease. So when you speak of hormone therapy, it can be an estrogen alone. So you give this if the patient already has had a surgery wherein the uterus and ovaries were both removed. Except in cases of endometriosis, if the indication for the surgery was endometriosis, you still give combined estrogen and progestogen. We also have what we call our selective estrogen receptor modulators. Unfortunately, these are not available locally. Raloxifene, I think there is still one brand that is available locally. And we have also steer. So this is also a form of combined hormonal therapy. Tibolone is available locally with 3 actions. So it's an estrogenic, it's a progestogenic, and it has an androgenic effect. So to supplement women whose chief complaint is sexual dysfunction or reduced libido. So these are just the sample preparation. So again, reinforcing Majoy's lecture. Now, because of the WH trial, the older age population, the standard dose, now the aim is to give the lowest dose that alleviates the symptoms and affords benefit to these women. So studies have shown that even if you give the ultra low dose or the low dose, it addresses the vasomotor symptoms, also protects the bone from bone loss. Okay, so again, the type of progestin is very important. So if you see in the WH trial, the progestin that was used was hydroxyprogesterone acetate, which is has a more adverse lipid profile. Okay, so now the studies have shown that if the patient is, let's say, obese, has diabetes, although controlled, you may has a family history of breast cancer, then you may lean towards the transdermal route, like what Majoy mentioned, and choosing the dydrogesterone or micronized progesterone as combinations to negate the increased risk for breast cancer. Okay. Some may also use the levonorgestrel releasing IUS. So this is an intrauterine device that can stay with the patient, for those with an intact uterus, for 5 years. So again, this is just to emphasize, kasi diba, there's that scare. What is the scare? The incidence of deep vein thrombosis, all-cause mortality, breast cancer risk. Okay, so this is studying those women who were stratified, the 50 to 59-year age group, discussing the all-cause mortality, whether it is significant for those who were put on the combined equine estrogen trial or the combined equine estrogen plus the medroxyprogesterone. So these are the younger women. So what the overall benefit is that there was a decrease benefit from mortality. So blue is good. From all types of cancer or from dying from any cause. Okay, there was a protection from all fractures for both users. If you see here for the CEE, even the breast cancer, there was no increased risk for this. That's why we mentioned that maybe the progestin has also a contributing factor. Even there was no increased risk from dying from coronary heart disease. This is the line that will define what is statistically significant. So only the DVT was significantly increased, and these were followed up for 18 years. Okay, so it means that even if there's an additional risk from breast cancer, that is, Majoy mentioned 4 in 1,000. This is six cases in 10,000 women years. So the absolute risk is low. Okay, so time of initiation, just to emphasize, this is now. So this is complementing the PSCM guidelines, still true. It's best to start, meaning you can start as soon as you're menopausal, sometimes even perimenopausal, as long as you're less than 60 years of age and within 10 years from the onset of menopause. But if you want to start it past 60, okay, or more than 10 or 20 years of age, then the risk may be more than the benefits because of greater risk for coronary heart disease, stroke, VTE, and dementia. Okay. So Majoy also mentioned, again, from the NAM's recommendation, how long should you take it? So now there is no more cutoff. You should stop taking it after 5 years. In healthy women, as long as it benefits them, they may continue as long as you are monitoring the patients, okay, and give the lowest dose possible. So how do we manage? We may give our hormone therapy, still said as the most effective treatment for vasomotor symptoms and genitourinary syndrome of menopause, and has been proven to prevent bone loss and fracture. So we risk assess the patient. So we give the particular route, the dose, and the duration depending on the risk factors that the patient has, and also the progestogen, the type of progestogen, whether we give it cyclic or continuous, and the kind of progesterone are also equally important. We should individualize treatment and always be assessed by the latest evidence. So what I say now may change 2 or 3 years from now. That's why we need to continuously update ourselves. So when we talk of aging now, the new term is not only like healthy aging, it's successful aging, right? So we want our older, so this is a picture of my mom. She's my idol. She's the yaya of all of us. That's how healthy she still is. So we want our aging women not only to be aging beautifully, but to not suffer from chronic diseases. They should be still engaging in their social activities with adequate mental health. And they lack physical disability. Diba? It's so degrading. My mom hates using a cane. So we want them to be still productive members of the society. So how do we do this? We optimize opportunities to improve and preserve holistic midlife wellness, independence, and quality of life. So happy World Menopause Month po sa ating lahat. Thank you very much.
Wow, thank you very much, Dr. Duchess. Ang ganda ng presentation.
Galing, galing.
No? I mean,
Thank
if you're
you.
not convinced by now, I don't know. Very, very convincing. I learned a lot. And I think this is really a, what should I say? We're at a good takeoff point for discussion and questions. But I think we have a break, Raymond. Go ahead.
Yes, well, for now po, no, we're asking our speakers to turn on their videos, and while they're doing that, we'll take a very quick break for a special public service announcement today.
Ay, ate, gusto ko nang lumabas at makipaglaro.
Eh di ba magkakasakit daw tayo kapag lumabas?
Magpe-face mask naman ako eh.
Kahit na, hanggat wala daw tayong injection, hindi tayo pwedeng lumabas at maglaro.
Ano ba yan? Takot pa naman ako sa injection.
Huwag ka mag-alala. Parang kagat lang daw ng langgam yun.
Talaga? Eh, natatakot pa rin ako.
Eh di sabay na lang tayo.
Pa-injection?
Oo, syempre. Loves kita eh. Para makapaglaro na tayo.
Dahil mahal ko kayo, magpapabakuna ako.
Kaya mga bata, magpabakuna na kayo.
Stay safe and stay well. Mga bata, magpasama na sa Bakuna Center. Thank you, TVUP, the COVID Communication Public Service Announcement, just one of the many creative outputs of the team to push for COVID-19 vaccinations. So please share this video clip in our social media accounts. Stay safe and stay well. Magpasama na po sa Bakuna Center. Let's start the ball rolling, Dr. Susie.
Okay, thank you very much to our two speakers. You'll see the appreciation of the audience in the chat box. And when you were talking, there were some hearts and clapping hands going up. So I think we all learned a lot from this. So, at first, for me, I think the first question is, what does this cost? Kasi, parang, of course, the arguments that you have made are very, very strong. And I guess the thing is, how do we get more women to benefit from it? But let's talk about, how is this financed? How is it costed out? Is it affordable?
Me?
Yeah,
Dr. Majoy, yes po. Yes po.
Yes, go.
Okay, so it will definitely depend on the type of MHT that you will use. Okay, so right now, I favor using the transdermal MHT. If I'm not mistaken, it's about 1,000 pesos. If you use the low dose, so it's
800.
like
It's 800 lang,
di ba,
Joy.
ma'am?
But you use it for a long time.
Right. So it might be good for a month. Okay, so one sip and then
quite
No, it's not. It's not good for a month. It's matagal siya. Kasi if you use the ultra, sorry, Majoy. Yeah, it's around 800, legit, in the Mercury drug, because some they sell it in Lazada. It depends, kasi it's a ruler, so it's the standard dose, the low dose, the ultra low dose. If you just use half a ruler, it will last you more than a month.
2 months,
Sometimes
but
even
if
3 months.
yeah,
And then you have to complement it with an oral progesterone, which
Or
is
vaginal.
like 60 pesos a
day.
tablet if you use it sequential, if you use it for 14 days only of the month. So you don't have to use it the whole 30 days. Some would want a continuous for those who are immediately menopausal, because they are bothered with sometimes you get like a sort of irregular bleeding. So it causes panic. So if you're just menopausal, you can go to a low dose progesterone also, so it's cheaper, and then that estrogen that you use every day. And then when, let's say 1-2 years after, you can just shift to a 14-day progesterone, and then that tube, or if tibolone is a combined, already an oral, estrogen, progestogen, androgen. Those who are really very healthy, meaning they don't have any risk factors for stroke or heart disease, you can use that. That's I think 1,000 plus
Right.
a month. That's already a month.
Mhm.
Plus, of course, I'm sorry, I think we forgot to tell them they should also take their calcium with vitamin D to help the bones.
Right. So to get on therapy, do they have to see an obstetrician, or can this be done already at health centers?
Actually, ma'am, in some countries, actually, even in us, in provinces, the FAMED or general practitioner gets to
Yeah.
see these women.
Oo.
So they can assess. So at least a minimum requirement is we do not want any contraindication. So
Correct.
minimum requirement is they should have had a breast a mammography, at least a pelvic exam if a transvaginal ultrasound is not available. But if it's available, better to have a transvaginal ultrasound. And then if she's obese, check the blood pressure. She can have a baseline lipid profile and sugar. Again, diabetes and dyslipidemia are not contraindications, but it's just that we monitor these and we give the transdermal route.
Right.
But if they're relatively healthy, they're non-smokers, they're fit, right after you do the test, you can start them on anything that they want.
Wow, that sounds like really good news for a lot of women. Thank you for
Right,
that.
Doc. But
Oh,
you know
sige, go
what?
ahead.
The ironic thing here is even the OBGYNs are afraid to use it.
Okay.
So that's
Not
what we
even
are
use,
trying
prescribe.
to do. Sorry, prescribe it. Correct. So that's what we want to try to undo. That in the
Yeah.
properly selected group of patients, it is actually really beneficial. And we think that they should start it, especially if they really have bothersome symptoms.
Yes, I think both ways, no? Parang the education of doctors and also the education of the patients, very, very important. But I think you've made very strong arguments, and you've shown very clear evidence on the benefits and how they outweigh the risks. Raymond, do you have a question over there? I'm gonna look at the Q&A box.
Okay. Question, a little bit, I want to say fundamental po, no? Question would be, nasaan na nga yun?
Sa Q&A ba?
Hindi. This one is from when we scanned it. So, how do I know if I'm approaching menopause? Yun po yung kanyang tanong. Yun.
Interesting
Okay.
question. Yeah,
Aba,
that's an
aba.
interesting question. Yeah.
Dr. Majoy, sige ma'am.
Approaching. So one of the more obvious signs is that there will be some menstrual irregularity. So usually a woman the cycles will become not the usual that they would expect. Regular menses would usually space out. Okay, some degree of parang abnormal bleeding na yan. But ang usual pattern will be pahina po, and then the menses will start skipping. And during this time, some patients will actually manifest with symptoms of estrogen deficiency, like what we presented earlier. So hot flushes will start coming in. Some will present with night sweats and some irritability. So approaching menopause. But of course, you'll have to take this into context, woman's age as well. Okay, so usually that will be about 45 years old and above, that would be the usual. So yan yung perimenopause period, yung po yung tinatanong, no? Approaching menopause.
Okay, go ahead, Raymond. If you don't, I have a question. I have a question.
Yeah, go ahead.
Sige. So let's say, okay, let's think about all the women in the Philippines, like who are in that particular age group, maybe 20 million or so. What's the best way? What do you think is the best way to reach them, or to educate women about the safety and the effectiveness of using replacement therapy?
Yeah, Ma'am Duchess, they have this caravan. They're
On our
doing so much work. Yeah.
on our part, actually, yeah, the society is for the year we've been having lay forum, and we're conducting regular. So for the doctors, we're doing our monthly webinars. And starting next year, we will go back to face also. Like, we will be visiting the regions because they clamor for it now. It's safe. But aside from that, we also conduct. So for this year, we had two lay fora, going to specific areas where we think hopefully we can recruit patients or increase awareness. But during this whole month of October, like I mentioned, so the whole from region 1 to 12, there has been lay lectures, Zumba activities. Last Sunday, we were just in Legazpi. We had the menopause walk for menopause in by Mayon Volcano, wherein the local government was very active. So the mayor was there, the governor was there. There were tarpaulins. If you had money, a commercial TV advertisement will be right, like what the cervical cancer did.
Yes.
So that's our next aim.
Yes.
Just to tap famous celebrities who are not shy to admit that they are menopausal.
Correct.
Like when we had this talk last year with Karen Davila, we sort of like interviewed each. She said that she's people like that who say that I'm using hormone therapy and it's safe. That will be, I think, for our Filipino community will be best. But for now, we are limited by budget, so I'm hoping to tap some people for next year's activity.
Wow, that's
Ma'am
great.
Duchess,
Wonderful.
yeah,
Go ahead.
social media like TikTok and
Oo
mga
nga
ganyan.
Yun na nga but I'm not, the International Menopause Society, actually some Asian, because we're part of the Council for Affiliate Menopause Societies in Asia. So some resorted to those TikToks nga raw, and so we will also tap the younger members of the society to look into those, because I am not a TikToker. I am not into that area that much. But Ma'am Susie, baka ma-invite ka namin. So if that will come, you will be but you did not miss MHT.
What?
So
No, I did not. Because
so
I
your
was-
tagline will be, I regret.
I wish I did.
Oh,
Now I can't
yes.
anymore, or maybe I can. I don't know. Yeah, but I'm happy to help. We here at TVUP are happy to help you in whatever way. If you have some ads you want to put here, fine. Because I think this is one of those instances where we promote wellness, right? And we're able to prevent, a lot of suffering from women who do have severe symptoms. As I mentioned, mine were really so mild, but I have friends who were really debilitated by it. So I can really relate to what you're saying in relation to severe symptoms. But that's excellent. Great, great, great. Okay,
And
Raymond.
you're also a TikToker, di ba, Dr. Susie?
Hindi na, stop na eh. I got
Millions of followers.
No, I'm not on TikTok. I just watch it so that I just find it funny. So, but
I watch it kasi my daughters are there, so I have to see what they're posting.
Yeah. So anyway, sige, Raymond, one last question. Then we have to go to the answers to our Q&A, and then do our evaluation. So Raymond, one more question from you.
A question, so this is also outside of the Zoom, but the question is, are there any, I guess ang tanong niya kasi, are there any psychological or emotional effects when you take that hormone therapy? Yun po, ang tanong niya.
Actually,
Go ahead, ma'am.
Yeah, go ahead. Actually, it improves. It improves your emotional life. Like personal experience, my daughters used to call me bipolar. At the height of my I would shift. That's why I was so bothered. That's why I started taking it. It's not really the hot flush also bad, but the that's why now I empathize with my patient. It's not drama.
It's the mood swing.
Yeah, mood swings that you want to kill everybody. Di ba yung parang at the verge of quitting lagi yung secretary ko when I have this. Yeah, so it improves their emotional. Kasi if that is the complaint, so your sleep is better. Kasi what Majoy mentioned, it's not only that you find it hard to sleep, you find easy wakefulness. Diba? Somebody texts you, then you wake up. Then you cannot, difficulty getting back to sleep. So that in itself affects your mood. And because of your mood, you lose, the sexual dysfunction is not only because of the atrophic vaginitis, but also the feeling of being down, right? And of course, you feel you're uglier when you're getting old. So in a way, again, when you have these are the small, it's not shallow. It's not shallow. Do not disregard any complaint of the woman. Diba? They will not see the osteoporosis benefit or the cardiovascular benefit or the dementia benefit. No, what they see now is what they feel. So they want to be addressed with what they feel and to reassure them that, oh, if you take this, low dose, and then you start at the lowest dose, if it alleviates them, then okay na yan with the dose, but it's safer. So they don't get scared.
So some of
I
my
really
patients
go ahead.
some of my patients say it's as if a dark cloud has been lifted from them. Parang they feel
Yeah.
really much better. Pero ang totoong maging thankful sa akin, yung mga asawa. Kasi
Yeah.
hindi sila susungitan. Tapos, of course,
Exact.
there is that attempt to actually reinitiate being intimate again with them.
Yeah.
So, yun,
Yeah.
sila yung talagang nagpapasalamat po sa amin.
You know, I really like your approach, Duchess and Joy, because the family suffers every time, if the woman is out of balance, everybody suffers, no? And I really like that idea of the quality of life. If the woman is feeling pumapangit siya, masama ang mood niya, the effect on children of that is terrible, no? It can be very
Yes.
traumatic and it can be traumatic for marriages. So I think this really speaks to wellness, quality of life, and self-care of women. And as I said, TVUP, our team is very happy to help you get the word out. So thank you so much for being with us. And we hope to hear more from you. Okay, Raymond, let's go to our fun quiz.
Okay, can we have on the screen Slido at saka yung sa Zoom po? Okay. So for the first question, we'll have it by Dr. Duchess, and then second question by Dr. Majoy. We'll need to have Slido muna on the screen. Sige. Okay. First question. So I'll read the question and then I'll point to the expert po. No? So first question, when should one start taking menopausal hormone therapy? Dr. Duchess.
So as soon. So the best, like what Majoy said, is that window of opportunity. So as soon as you hit menopause, sometimes even when you're irregularly menstruating, and you're already symptomatic, you're beginning to feel the hot flashes, you may already be started. And then you can continue it even past 60 as long as you started it earlier. So it depends on the symptomatology. So the correct answer is A. Ayan, 100%.
Opo. In the Zoom naman po, 58%. The second closest po is none of the above, but we're glad that the majority of those who answered the question got it correctly. Thank you, Dr. Duchess. For our second question, for Dr. Majoy, what are the indications for MHT?
100% din ba talaga to?
Perfect. In Slido, but in the Zoom, if you're seeing it, iba yung number.
All right. So yes, we did mention the indications to start MHT. So moderate to severe vasomotor symptoms, prevention of osteoporosis in postmenopausal women, and moderate to severe vulvovaginal symptoms. So again, it has to be clear why we're starting it. Okay, the use of MHT has to be indicated when we start it. And the other one will be yung hypogonadism symptoms.
Okay.
So D.
Letter D, all of the above. So in Slido, isa lang po yung sumagot, so 100%. But dito po sa ating Zoom, 88% ang pumili po ng all of the above. The next closest will be moderate to severe vasomotor symptoms. So thank you. Sana po maalala po ito ng ating mga tagapanood, tagapagsubaybay, at something that if you want to watch it on the playback, it's still going to be there. Okay, so right now we'll have our panel evaluation poll po muna, and while that is showing up on the screen, there we go. We will ask our speakers to come up with, let's say, their parting words. So what do they want to leave the audience with? If there's anything that they want the audience to take away from the webinar, ano po iyon? I'll read the 5 statements here, and then we'll move on to your parting words. First statement, the panelists demonstrated thorough knowledge of the topic. So is it strongly agree, disagree, strongly disagree? Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. So we will not be closing this discussion poll or evaluation poll until the end of the webinar. We also do not send out a separate one. This is it. So we encourage everyone to participate and put in your inputs in panel discussion poll. Dr. Susie.
Okay, thank you very much, everyone, and thank you for participating in the evaluation. And of course, thank you so much to our 2 wonderful speakers today, and we're going to give them a moment to say a few words or parting words for today for our audience to take home. So we'll start with Dr. Duchess. Please go ahead.
Thank you again for this invitation. I was so happy in Dr. Jose, because being president of the society, this is one of my sort of passion for the until next year. So take home message is we deserve to live gracefully, beautifully, and healthy. Okay, so I don't speak only as a menopausal woman, but I this is a clamor for all our patients. So I challenge the health practitioners, please don't be afraid to prescribe. So risk assess your patients. Okay, and once you have risk assessed, you assess the chief complaint, you give the medication, and you always tell them to please follow up. Okay, so because with the evidence, if used properly, the lowest dose available and monitored, it's the safest, and we benefit. It's not only the person, like what Ma'am Susie said, it's the family, it's the society, it's the global benefit. Okay, thank you.
Thank you so much, Dr. Duchess. And then let's go to Dr. Majoy. Go ahead.
Ma'am Duchess, yun na yun eh. She said it so well. So women can age gracefully. So the menopausal years do not have to be, women do not have to suffer during that time. So, you know, as long as it is properly used, clearly indicated, started during that window of opportunity, and the women are monitored appropriately, then, you know, definitely the risks will outweigh the benefits will definitely outweigh the risks with the use of MHT. So let's not be afraid to consider it or to use it when the woman needs it.
Okay, thank you very much. Thank you to both of you. We cannot thank you enough. And I think our audience, again, you can see in the chat, they're very grateful for all the information you shared with us today. But before we go to our closing remarks, Raymond, do you want to read the results of the evaluation? Go ahead, please.
So preliminarily, we're seeing base here very, very high. So at least 95% of all those who participated dito po sa ating evaluation poll strongly agree with all of the statements. Just a testament po, not just on the topic at hand, but the quality of speakers that we had for this webinar. So we'd like to thank Dr. Majoy Cristi Limson and Dr. Duchess Banalsilao for gracing our webinar po and sharing your insights on the topic. Dr. Susie.
Okay, we go to our closing remarks, and I'm sure she's the one who engineered this topic. Dr. Stella Marie Legaspi Jose, who's going to give us our closing remarks. Stel, take it away.
Good afternoon, everyone. Thank you for attending our webinar. It's been a very enlightening webinar for almost all our viewers. So, looking at the chat box, I myself, I took MHT when I was in that period of my life. So I attest to the benefits of the medicines. Okay, so from Dr. Majoy Limson, she mentioned, and I just want to emphasize, especially to all the doctors out there, the indications for hormonal replacement therapy or menopause hormone therapy. First is the treatment for postmenopausal women disturbed by symptoms of hormone deprivation, such as hot flashes or atrophy of the reproductive system. That's hot flashes. It's really so hard, no? So if you're in that stage and you get really hot-headed, that's a sign of hormonal deprivation. And then second is prophylaxis against osteoporosis. Once a patient, a woman gets a hip fracture, she becomes bedridden for life. No, you can have an implant, but they cannot anymore live like ordinary people walk and do the things that they used to do like that. So no more. So osteoporosis is a very big issue here, and I think we should help our patients. And third is premature hypoestrogenism. So that's one of the indications. So when you have hypogonadism, primary ovarian insufficiency, dumadami na yung ganyan, early menopause, 40 years old, nag-menopause na. I see patients like that, 38 years old, and they're already menopausal. And so they really need MHT. So yung mga gonadal dysgenesis, these are inborn errors, no? So, and also premature surgical menopause. Some patients would undergo total hysterectomy and bilateral salpingo-oophorectomy, even if they're young. Sometimes it happens with some doctors that they remove everything, but it can really be that the ovaries can be spared, no? So, let's not be afraid of MHT. From Dr. Duchess Banalsilaw, she mentioned that the FDA approved 4 indications for MHT. First is moderate to severe vasomotor symptoms, as mentioned earlier. Second is the prevention of osteoporosis in the postmenopausal woman and the treatment for hypoestrogenism caused by hypogonadism, bilateral oophorectomy, and premature ovarian failure. Alam nyo yan, cause of discord between husband and wife. Pagka nagkakaroon ng dryness of the vagina, sometimes it's really, gera yan, gera. And fourth is the treatment of moderate to severe vulvovaginal symptoms. Thank you very much for watching our webinar. Back to you, Susie.
Okay, thank you so much, Stel, for that great synthesis. And we are coming to a close. Next week, teka muna, Raymond, hindi ko alam ng topic next week. Anyway, we've got a great topic next week.
Trophoblastic disease.
Trophoblastic diseases, yes.
Trophoblastic diseases.
Yes.
Okay. Sige, you want to say something about it, Stella?
From the division of the trophoblastic diseases, we have Dr. Agnes Estrella and others who will talk on gestational trophoblastic disease.
Okay, great. So that's going to be very, very, very interesting for everybody. Join us next week when we take up trophoblastic diseases. Okay, Raymond, move to you.
Thank you, Ma'am Stella, and thank you, Dr. Susie. So, before we conclude our program, all Stop COVID Deaths webinars are archived for viewing at the TVUP YouTube channel at your convenience. So you just go to the www.youtube.com/TVUPPH, or you could search it in the YouTube app and go to TVUPPH under the live tab po. You'll be able to see all 168 webinars, and after the day 169 webinars. We also have what we lovingly call SCD shorts. These are very, very short consumable videos, nuggets of wisdom. Hopefully you'll gain from each of these short videos. What you're seeing also on the screen, especially for those who are in the Zoom, well, it's still 95%, but a lot more have been able to participate in our evaluation poll. So this formally closes our webinar for the week. Magkita-kita po tayo ulit next Friday from 12 noon to 2 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy, and see you online.